think about your morning routine today, before you even started studying.
Oh, yeah.
You probably just woke up, walked to the bathroom, maybe took a shower, got dressed, grabbed something to eat.
Right.
And you didn't sit there and map out the physics of how to maneuver your arms into your sleeves, right?
Yeah, of course not.
You didn't consciously calculate the exact angle of your neck while you were swallowing your coffee. These things are just, the invisible rhythms of our day. We take them completely for granted.
Yeah, I mean, they are deeply ingrained autonomic processes. Our brains and our bodies just handle them on autopilot. And because of that, we feel this complete sense of autonomy over our own lives.
Exactly. But when you step into the world of long-term care, or really any clinical setting, those invisible rhythms suddenly become, well, very visible.
Yeah, hyper visible.
Right. So for a resident who has experienced a stroke, or someone who is living with advanced dementia, or, someone who has simply lost mobility due to the natural aging process, those deeply personal, private moments become clinical tasks.
Which is a huge shift. Someone else has to manage them.
Right. And the landscape of how you navigate that as the caregiver, like how you literally physically place food into someone's mouth, or how you clean them after they've used the bathroom, it's fraught with physical risks and really profoundly sensitive emotional dynamics.
It is the absolute definition of physical and psychological vulnerability. I mean, you are taking the most private, guarded aspects of a human being's existence and placing them entirely in the hands of another person. The power differential there is just staggering.
It really is. So welcome back to the deep dive. We know you were probably deep into your study prep right now, maybe listening to this on your commute or just pacing around your living room trying to memorize all those skill steps.
Yeah, we've all been there.
You are in the right place. This is the Cert Prep Academy CNA Exam Prep Podcast. We are currently on an 11-part journey covering all 6 of the NNAAP written exam topics.
And if you are just joining us for the first time, every single installment in this series stands completely on its own. You can jump around to whatever topic you need to brush up on whenever you actually need it.
Definitely. So today's mission is Episode 3, Physical Care Part 3. We are going to be looking at nutrition, feeding, and elimination. And there's going to be some heavy overlap with bathing, dressing, and mobility.
Yeah, because if you look at the NNAAP content outline, physical care skills make up a massive 14% of the written exam just for activities of daily living, or, ADLs, as you'll usually hear them called.
14% is huge.
It really is. That 14% directly encompasses hygiene, dressing, grooming, nutrition, hydration, and, of course, elimination. It's weighted so heavily because this isn't just theory, right? This is the absolute granular core of what a certified nursing assistant does for 8 to 12 hours a day.
Yeah, 14% is a number that can totally make or break a passing score. And, if you're using the practice tools on Cert Prep Academy, these topics are heavily tested. They pop up relentlessly.
Oh, absolutely.
And they often use these scenario-based questions that can be, well, really tricky if you're just trying to memorize a list of rules. So we're going to get deep into the weeds today. We'll look at the exact skills, the specific measurements, the literal angles of the bed that you need to know.
Because just memorizing a list of steps is incredibly difficult. And honestly, under the pressure of the actual exam, rote memory often just fails you.
Right, you blank out.
Exactly. So our goal today is to look at the mechanisms behind the rules. We want to explore the physiological anatomy and the psychological reasoning that dictate these skills. When you understand the actual mechanics of human digestion or the physiology of aging skin, the exam questions stop being a memory test.
They just become logical, common sense.
Exactly.
So let's start at the very beginning of the digestive process. Let's look at the foundations of feeding, because we all eat every day. But for a resident, mealtime involves highly specific safety protocols. It involves specialized diets and a really fundamental need to preserve their dignity. I was actually just looking at NNAAP Skill 10, which covers feeding a client who cannot feed themselves. And the very first thing the skill requires, before you even think about picking up a utensil, is checking the name card on the tray and asking the client to state their name.
Yes, safety first.
And I'll be honest, if you've been caring for the same person every single day for a month, asking them to state their name feels a little, robotic.
It can definitely feel formal, certainly, but you have to consider the environment. In a busy facility, trays are coming out of a central kitchen by the dozens.
Oh, yes, chaos.
Right, trays get bumped, cards get swapped, residents move to different tables in the dining room. That food tray is not just a meal. It is essentially a medical prescription.
Because of specialized diets and allergies, right?
Precisely. Say a resident has a severe shellfish allergy, or maybe they require a specific mechanically altered diet because they, lack the physical ability to swallow thin liquids safely.
Right.
Handing them the wrong cup of water or the wrong plate of food could literally be fatal. So the name check is a hard stop. It is a critical safety barrier designed to prevent a catastrophic error of misidentification.
Wow. Okay, that makes the stakes very clear.
Uh-huh.
So you've confirmed you have the right person and you have the right prescribed food. The next critical factor the exam just hammers on is positioning.
Oh, yeah. Constantly.
The resident must be sitting in an upright position. The specific numbers you need to know for the test are 75 to 90 degrees, so sitting almost completely straight up. Now, I have absolutely eaten a sandwich while slouched halfway down my couch or, lying in bed watching TV.
We all have.
Right. So why is the 75 to 90 degree angle so rigidly enforced for residents?
To understand that, we have to look at the anatomy of the throat. The human pharynx splits into two distinct tubes. You have the esophagus, which obviously goes to the stomach, and sitting right in front of it is the trachea, or the windpipe, which goes to the lungs.
Okay.
Guarding the entrance to that trachea is a small, leaf-shaped flap of cartilage. It's called the epiglottis.
All right, the epiglottis folds down to cover the airway when we swallow.
Exactly. When you are sitting at a 90-degree angle, gravity is working in your favor. When you chew and move food to the back of your throat, the epiglottis has time to fold down and seal off the trachea, and gravity just pulls that bolus of food straight down into the esophagus.
Makes sense.
But if a resident is lying flat, or even just leaning backward at, a 45-degree angle, which, by the way, is a very common distractor answer on the exam, that anatomical dynamic changes entirely.
Is it because gravity is pulling the food toward the back of the throat before the swallow reflex is fully triggered?
Yes, exactly. The liquid or the food slides backward way too quickly. The epiglottis, especially in older adults who may have weakened muscles or delayed neurological reflexes, just cannot close fast enough.
Oh, wow.
So the food bypasses the esophagus entirely and slips directly into the open trachea.
Which brings us to a massive vocabulary word for the exam, which is aspiration.
Aspiration. It is the medical term for when food, liquid, saliva, or even vomit enters the airway in the lungs instead of going into the stomach.
And the consequence of aspiration isn't just coughing, right? It's aspiration pneumonia.
Which is incredibly dangerous and, frankly, frequently fatal for the elderly. Think about it. The lungs are a sterile, moist, warm environment.
Yeah.
When you introduce foreign food particles and all the bacteria from the mouth into those lungs, it creates a massive, rapid infection. So positioning a resident at 75 to 90 degrees, or, as close to 90 as they can physically tolerate, is absolutely non-negotiable for safe swallowing. It gives their anatomical reflexes the mechanical advantage of gravity.
What I find fascinating, though, is that the NNAAP skill doesn't just dictate the resident's position. It actually dictates the CNA's position.
Yes, it does.
The skill requires the candidate to sit in a chair facing the client during the feeding process. And my initial thought when I read that was, wouldn't it be more efficient to just stand next to the bed? You have better leverage, you can move faster.
Yeah. Efficiency and speed are the enemies of safe, dignified feeding. Let's look at psychological and physical mechanics of standing over someone while you feed them. First, just the physical aspect. If you are standing, your hand is moving down toward their mouth, right?
Yeah.
So the resident instinctively tilts their head back and looks up to see the spoon coming.
Oh, wow. And if they tilt their head back, they're opening up the airway. We just talked about how dangerous that is.
Exactly. Tilting the chin up extends the neck and actually makes it mechanically harder for the epiglottis to close. You want their chin neutral or even slightly tucked down when they swallow.
Right.
By sitting down at eye level, the utensil comes straight in, which allows them to keep their head in a safe, neutral position.
That is such a clear, mechanical reason. But there is a psychological layer here too, isn't there?
A profound one, yeah. Imagine being confined to a bed and someone is just standing over you, hovering, periodically dropping food into your mouth. It creates this stark, really uncomfortable power dynamic.
It feels rushed.
Yes. It sends this subconscious message that you are just a task on their checklist, just a chore they are trying to hurry through so they can get to the next room.
It kind of strips away their personhood.
It does. When you pull up a chair and sit facing them at eye level, You are physically placing yourself on equal footing. You are engaging in a shared activity. It shifts the entire interaction from being task-focused to being person-centered.
I love that.
Furthermore, sitting facing them allows the resident to actually see the food on the tray. It allows them to read your facial expressions, which is crucial if they are hard of hearing. It just facilitates a normal human interaction.
I really appreciate that framing. Person-centered care isn't just like a buzzword. It dictates the literal physical stance you take in the room.
Absolutely.
And that philosophy extends directly into the feeding process itself. You don't just sit down and start shoveling food into their mouth. The skill requires you to tell the client what foods and beverages are on the tray. You have to ask them what they would like to eat first.
Because choice is a fundamental component of autonomy. Think about when you eat a meal. You naturally vary your bites.
Yeah, a bite of chicken, some potatoes, a sip of water.
Right, you curate your own sensory experience. When someone loses the ability to feed themselves, they lose that sensory curation.
So as the CNA, you have to sort of narrate the meal. You offer one bite at a time and tell them the content of each spoonful. Like, here is a bite of mashed potatoes, or would you like some carrots next?
Yes. It provides predictability. It eliminates the anxiety of a surprise texture or a weird temperature hitting their palate, and you must consistently offer beverages throughout the meal.
Just continuously.
The standard is to offer a drink at least once, but practically you should be asking if they are ready for a sip or another bite continuously. Moisture is absolutely necessary to form the food bolus for a safe swallow.
Let's transition slightly into the types of food you might be serving, because specialized diets are heavily tested. You're going to see questions about what these diets actually entail. Let's start with a mechanically soft diet. If I see that on a tray card, what does it physiologically mean for the resident?
A mechanically soft diet involves foods that have been physically altered to require minimal chewing.
Okay.
This means meats are ground up or finely chopped, vegetables are cooked until they are very soft or mashed. It does not mean the food is pureed into a liquid paste. It still has some texture, but the mechanical labor of breaking it down has already been done in the kitchen.
So why would someone be prescribed a mechanically soft diet instead of just a regular diet?
Often it's related to dental issues, missing teeth or poorly fitting dentures that make grinding tough foods painful or just impossible.
Oh, that makes sense.
It is also prescribed for residents who experience severe chewing fatigue. The muscles of the jaw can weaken with age or with certain neurological conditions, and literally just chewing a piece of steak could exhaust them before they've consumed enough calories to maintain their weight.
So here's a scenario that comes up in the practice materials. Say you are feeding a resident who is on a mechanically soft diet, but you notice they are still really struggling, like they're pocketing the food in their cheeks, they seem exhausted. Can you, as the CNA, just ask the kitchen to switch them to a puree diet to make it easier for them?
No, you absolutely cannot. Altering a diet is completely outside your scope of practice.
Even if your intention is just to help them. I mean, you can see they're tired.
Intentions don't override clinical protocols, unfortunately. A diet is a medical order. Changing it requires a formal assessment, usually by a speech-language pathologist or a nurse, and an order from a physician. If you notice a resident struggling, your responsibility is to observe those specific signs. So, pocketing food, excessive coughing, severe fatigue, and report them immediately to the nurse.
You can't just take it upon yourself to modify the texture.
And you certainly should not just reduce their portion sizes to make the meal go faster, because then you are actively compromising their nutritional intake. You observe, you document, and you report.
Another diet that shows up frequently is the low-sodium diet. What is the physiological goal here, and what is the CNA's role?
Well, sodium, or salt, acts like a magnet for water in the human body. Where sodium goes, water follows. In a healthy young body, the kidneys easily filter out excess sodium. But many elderly residents suffer from cardiovascular issues like congestive heart failure or severe kidney disease.
So if they consume too much sodium, their bodies retain excess water.
Exactly. That excess water builds up in the bloodstream, which increases the volume of blood the heart has to pump. It raises blood pressure and forces a weakened heart to work much, much harder. The fluid can also leak into the tissues, causing severe edema or swelling in the legs and the lungs.
Wow. So a low-sodium diet is quite literally protecting their heart and lungs from drowning in retained fluid.
Yes. So your role as the CNA is to ensure that the correct low-sodium tray is delivered. Now, the resident might complain, Hospital food without salt can taste very bland, especially to older adults whose taste buds have already diminished. They might ask you to go get them a salt shaker.
I imagine it's tempting to just give them a little packet of salt to make them happy.
It is very tempting, but doing so is a direct violation of a medical order. You cannot add salt, you cannot bring them salty snacks from the vending machine. You must calmly explain that the diet is prescribed by their doctor, and if they are truly unhappy, you report their dissatisfaction to the nurse, who might be able to consult a dietitian for alternative flavor enhancers like herbs or lemon juice. But you never take it upon yourself to bypass the restriction.
Okay, let's talk about the nightmare scenarios. Because feeding someone who has compromised anatomy is inherently risky. We saw this addressed in practice question 27 and question 51 from the source material. Imagine you are carefully feeding a resident. They're sitting up at 90 degrees, you're going slow, but suddenly they start coughing violently after a bite.
Okay.
Instinctively, human nature tells us to hand them a glass of water to wash it down. Is that the right move?
It is the absolute wrong move. If a resident begins coughing while eating, your immediate action is to stop feeding them. Do not offer water.
Why is water dangerous in that exact moment?
Coughing is the body's natural, forceful mechanism to clear the airway. It means the airway is at least partially open, and the lungs are pushing air up to expel whatever is irritating the vocal cords or the trachea. If you introduce a liquid into the mouth while they are rapidly gasping for breath between coughs, that liquid is almost guaranteed to be aspirated straight into the lungs. Furthermore, the water could wash the solid food particle deeper into the airway, turning a partial obstruction into a total obstruction.
Oh man, so what do you do? Just sit there and watch them?
You stop feeding, you remain calm, and you assess. You encourage them to keep coughing. If they can cough forcefully, their airway is clear enough to move air. You stay with them, monitor their color, and notify the nurse.
And if they stop coughing?
If the cough becomes wet or they cannot make any sound at all and they are clutching their throat, that indicates a complete airway obstruction. And you must immediately initiate emergency choking procedures like the Heimlich maneuver and call for help, but you never, ever try to flush it down with water.
Let's look at the other emergency scenario mentioned in those practice questions. Residents who receive their nutrition through a tube, feeding vitae, perhaps an NG tube that goes down the nose into the stomach, or a PEG tube directly through the abdomen. What if a resident receiving a continuous tube feeding suddenly starts vomiting?
That is an immediate high-priority emergency. Normally, the sphincter at the top of the stomach keeps food down, but if the stomach becomes too full or the intestines aren't moving the liquid nutrition along, it can back up and cause vomiting.
And because they often have altered levels of consciousness or weakened reflexes, the risk of them inhaling that vomit is huge.
It's astronomically high. If a resident vomits during a tube feeding, your very first action is to stop the feeding pump immediately. Cut off the source.
Okay.
Your second action is to physically turn the resident onto their side.
Because turning them on their side allows gravity to pull the vomit out of their mouth and onto the bed, rather than letting it pool in the back of their throat where it can slide into the trachea.
Precisely. You roll them laterally, you never lay them flat on their back, as that guarantees aspiration. Once the feeding is stopped and they are safely positioned on their side to drain the airway, you hit the call light and notify the nurse immediately.
Yeah, Cert Prep Academy has a ton of practice questions around aspiration risks and feeding angles, right? It's a huge safety issue.
It is. In a clinical emergency, you don't have 5 minutes to debate your options. You have seconds. Understanding the anatomy of why we turn them on their side locks that sequence into your brain.
All right, let's follow the physiological journey here. We've talked extensively about input and digestion. Eventually, that nutrition has to be processed and expelled, which brings us to the elimination of waste, and specifically how managing that output is intimately tied to skin integrity.
Right.
It's interesting. You might think skincare and bowel movements are two totally separate topics, but they are completely interdependent.
They are inextricably linked. The skin is the human body's largest organ, and its primary function is to serve as a defensive barrier against the outside world. It keeps moisture in, and it keeps bacteria and pathogens out.
Right.
When a resident experiences incontinence, so the involuntary loss of urine or feces, that defensive barrier is placed under severe immediate threat.
Let's break down exactly why urine and feces are so damaging to the skin. It's not just that it's wet, right? There's a chemical component.
Very much so. Healthy skin has a slightly acidic pH, often referred to as the acid mantle. This acidity helps keep bacterial growth in check. Urine, on the other hand, contains urea. When urine sits on the skin, the bacteria naturally present on the skin begin to break down that area into ammonia.
And ammonia is highly alkaline. It's literally a harsh cleaning chemical.
Exactly. The ammonia rapidly alters the pH of the skin, stripping away that protective acid mantle. It acts as a chemical irritant, causing severe inflammation. The skin becomes bright red, painful, and inflamed.
So it causes excoriation, well, skin breakdown.
Yes, excoriation, or incontinence-associated dermatitis.
Furthermore, there's the moisture factor itself.
Yes, maceration. Think about when you stay in the bathtub for too long, or leave a wet Band-Aid on your finger. Your skin gets white, wrinkled, and soft.
Yeah, it gets pruny.
Right. That is the stratum corneum, the outermost layer of the epidermis absorbing water like a sponge. When the skin is macerated from sitting in a wet incontinence brief, it becomes incredibly fragile. It loses its tensile strength.
So if you have chemically irritated, macerated, waterlogged skin, and then the resident shifts their weight in bed or you pull them up by their shoulders.
The friction tears the skin right open. It shears the top layers off entirely. And once that barrier is broken, the bacteria from the feces, which are abundant and highly infectious, have direct access to the underlying tissues. It is a rapid downward spiral into severe pressure ulcers and systemic infections.
Wow. So knowing this chemical and physical cascade, what is the mandatory immediate action when a resident is incontinent?
Promptness is your only defense. You must change soiled clothing and bedding immediately. You must cleanse the perineal area gently but thoroughly using mild soap and water, or a specialized pH-balanced cleanser.
Oh.
And then you carefully pat the skin dry, never rub, because rubbing causes those friction tears. Finally, you apply a moisture barrier cream as directed to protect the skin from future episodes.
I want to push back on this a little bit, looking at it from the reality of a chronically understaffed facility. You might have 10 to 12 residents assigned to you. Doing a full bed bath and linen change every single time someone has a minor episode of incontinence takes a massive amount of time. Isn't it just faster or more practical to put a protective plastic pad down directly under the resident, or just slap a new brief over them so you can keep moving?
It is a harsh reality that time is a luxury CNAs rarely have. But medically and ethically, taking those shortcuts is indefensible. Let's look at the plastic pad scenario. If you place a resident directly on a plastic impermeable pad to save the sheets, what happens to the microclimate of the skin?
Well, plastic doesn't breathe, so it traps heat.
It traps intense body heat and sweat. The temperature rises, the pores open, the skin becomes instantly macerated from their own perspiration, even before an incontinence episode occurs.
Oh, wow. I didn't think about that.
Right, and when it does occur, the urine has nowhere to go. It pools directly against the skin. You have essentially created a greenhouse for bacterial growth and chemical burns.
So a plastic pad should never be against bare skin.
Never. There must always be a breathable, absorbent layer, like a cotton draw sheet, between the plastic and the resident. And regarding just slapping a new brief on without proper cleansing, you are simply sealing the ammonia and the bacteria back against the fragile skin. Masking the odor with a new brief does not stop the chemical breakdown. Prompt, gentle perineal care is an absolute non-negotiable standard of care.
Okay, to get ahead of the incontinence entirely, facilities rely heavily on toileting schedules. Instead of waiting for a mess, you preemptively toilet the resident. What does a typical schedule look like?
A standard protocol is to offer toileting every 2 to 3 hours during waking hours, and as needed or scheduled during the night.
Why 2 to 3 hours? Why not just wait for them to hit the call light?
Because many residents who require long-term care suffer from cognitive impairments like Alzheimer's or vascular dementia. The neurological pathways that signal my bladder is full may be damaged. They might not feel the urge until it is too late.
Right.
Or they might feel the urge but lack the executive function to plan how to get to the bathroom or use the call light. By taking them every 2 hours, you are emptying the bladder before it reaches maximum capacity, preventing the involuntary release. It also helps condition the bladder, maintaining some muscle tone.
We focused heavily on urine. Let's talk about the gastrointestinal tract. Constipation is a massive issue in the elderly population. Practice question 13 from the source documents highlights this. If a resident frequently complains of constipation, what are the basic non-pharmacological supportive measures a CNA can implement? Because obviously a CNA cannot prescribe a laxative or an enema.
No, medications are strictly outside your scope. But the holistic management of bowel health relies heavily on the CNA. The first measure is hydration. As we age, our natural thirst mechanism diminishes. An elderly resident might be chronically dehydrated without ever feeling thirsty.
Yeah.
When the body is dehydrated, the large intestine pulls water out of the stool to conserve fluid for the vital organs.
Which turns the stool into hard, dry, impacted rocks that are incredibly painful to pass.
Exactly. So, continuously encouraging fluid intake throughout the day is critical. The second measure is mobility. The gastrointestinal tract relies on smooth muscle contractions called peristalsis to move waste through the intestines.
Okay.
Physical activity like walking or even just active range of motion exercises in bed stimulates the autonomic nervous system to increase peristalsis. When a resident lies in bed all day, their bowels become as sluggish as their skeletal muscles.
Well, what's the third measure?
The third measure is providing absolute privacy during elimination.
I really want to zoom in on this because we see privacy come up in practice questions constantly. Often we think of privacy as just a courtesy. It's polite to close the door. But there is a hard physiological reason why privacy is required for elimination, isn't there?
There is a profound physiological link. The muscles that control the release of waste, the internal and external sphincters, are governed by our nervous system. The external sphincter is under our voluntary somatic control. But the internal sphincter and the muscles of the bowel wall are controlled by the autonomic nervous system. Specifically, the parasympathetic nervous system, which is responsible for rest and digest functions.
Okay, so rest and digest, meaning the body has to be in a state of calm.
Yes. Conversely, if a resident feels exposed, like if the door is cracked, if a roommate is listening, if the CNA is standing right next to them, tapping their foot impatiently, their brain perceives vulnerability. It triggers the sympathetic nervous system, the fight or flight response.
And when adrenaline hits your system, the body stops focusing on digesting and eliminating.
Exactly. Blood is shunted away from the digestive tract and toward the skeletal muscles. The sphincters instinctively clamp tightly shut. It is an evolutionary defense mechanism. You don't eliminate waste when you are under threat.
Wow.
So if a resident does not feel physically and psychologically private, they literally, anatomically, cannot relax the muscles required to have a bowel movement. This directly contributes to chronic constipation and severe pain.
That is wild. So closing the door and pulling the curtain isn't just about preserving modesty
Right.
or complying with HIPAA, though it absolutely does both of those things. It is a necessary physiological prerequisite for the organ system to function.
It is a biological imperative. Stripping a resident of their privacy strips them of their bodily functions.
That perfectly sets up our discussion on the actual equipment used for elimination. Because when a resident can't simply walk into a standard bathroom, lock the door, and have that guaranteed privacy, CNAs must rely on specialized equipment. And the NNAAP exam evaluates your competency on the exact sequential mechanics of using these tools safely. Let's look at NNAAP Skill 4. Assisting with a bedpan. Walk us through the physical mechanics of placing a bedpan correctly.
First and foremost, you gather your supplies, perform hand hygiene, put on clean gloves, and establish that physiological privacy by closing the door and pulling the privacy curtain. Then you focus on the bed itself. Before you attempt to place the bedpan, you must lower the head of the bed so the resident is lying as flat as they can tolerate.
Why do they need to be flat to place it?
Mechanics. To get the bedpan under their buttocks, the resident either needs to bend their knees and lift their hips, which we call bridging, or you need to gently roll them to their side, place the pan against their buttocks, and roll them back onto it. If the head of the bed is elevated, their body weight is entirely concentrated on their pelvis, making it incredibly heavy and physically difficult to lift. Lying flat distributes the weight and allows for a safe, smooth placement without shearing the skin of the sacrum.
Okay, so they are flat. The bedpan is positioned correctly under them. You remove those soiled gloves and wash your hands. What is the very next critical step?
You must immediately raise the head of the bed back up. The standard is a semi-Fowler's position, which is roughly 30 to 45 degrees, or even higher to a high Fowler's if they prefer and can tolerate it.
I remember seeing this on a Cert Prep Academy practice question. A lot of people get it wrong because they think once the bedpan is under them, well, the job is done. Why is raising the head of the bed so vital? Why not just let them use it while lying flat?
Try to conceptualize the physics of eliminating while lying perfectly flat on your back. It is entirely unnatural. The human body evolved to squat or sit to eliminate. When you are sitting upright, gravity pulls the waste downward, and it increases intra-abdominal pressure, which aids the muscles in expelling the waste.
Right, if you are lying flat, You are forcing the body to push waste horizontally, or even slightly uphill against gravity.
It requires immense straining effort, which can be dangerous for residents with heart conditions, and it rarely results in completely emptying the bowel or bladder. Raising the head of the bed mimics the natural seated posture of using a toilet. It aligns the anatomy with gravity.
And once they are finished, the process reverses. You lower the head of the bed flat again to remove the bedpan without spilling it, provide thorough perineal care, and ensure the skin is completely clean and dry before dressing them.
Exactly.
Now, what about residents who have a bit more mobility? They can get out of bed, but perhaps they can't walk all the way down the hall to the bathroom. This is where bedside commodes come in. If a resident is using a commode right next to their bed, what is the safety protocol?
The primary protocol is stability. You ensure the commode's wheels are locked if it has them, and you position it securely beside the bed. But you must not jam it tightly against the bed frame, because that creates a cramped, unsafe space for the physical transfer. The resident needs room to pivot safely.
Here's the friction point, though. We just established that privacy is a biological requirement for elimination. But the safety rules dictate that you cannot leave a fall-risk resident alone on a commode. How does a CNA balance the mandate for privacy with the mandate to prevent falls? Do you just stand there and watch them?
No, hovering over them eliminates all privacy and triggers that sympathetic nervous system anxiety we discussed. The balance is achieved through proximity and physical barriers. You pull the privacy curtain around the commode. You can step just outside the curtain or step just outside the bathroom or room door, leaving it open a crack.
Oh, I see.
You tell a resident, I'm stepping right on the other side of this curtain to give you privacy. I am right here. Call my name the moment you are finished.
So you are out of their visual field, allowing them to relax, but you are audibly monitoring them and are 3 steps away if you hear them start to slip or stand up unassisted.
Precisely. You preserve their dignity while maintaining immediate safety oversight.
Okay, we need to shift our focus to what is arguably one of the highest stakes, most heavily scrutinized skills on the entire NNAAP exam, catheter care. This is NNAAP Skill 18. If you've been doing practice questions, you know the exact direction and measurement of cleaning a catheter is an incredibly common question. Let's break down the daily care routine for an indwelling urinary catheter.
An indwelling catheter, often called a Foley catheter, is a tube inserted through the urethra directly into the bladder, held in place by a small inflated balloon. Because it bypasses the body's natural defenses, it is essentially a direct, open highway for bacteria from the outside world to travel straight up into the sterile environment of the bladder.
Which leads to a CIUTI, a catheter-associated urinary tract infection, and those can quickly become systemic blood-borne infections.
They are life-threatening. Therefore, meticulous daily catheter care is mandatory. The standard procedure for the exam requires washing the catheter daily with warm water and soap.
Not an alcohol swab. Not a harsh antiseptic.
No. Standard practice dictates mild soap and warm water. Harsh antiseptics can degrade the material of the catheter and severely irritate the delicate mucosal tissues of the urethra. You prepare your basin, expose only the area between the hip and the knee to maintain privacy, and place a waterproof pad beneath the resident. You apply soap to a wet washcloth.
And this is where the specific physical technique comes into play. You don't just scrub it blindly.
The technique is everything. Your non-dominant hand must grasp the catheter tube at the meatus, the exact point where the tube exits the body. You pinch it gently but firmly against the body.
Why do you have to hold it there?
Because if you just grab the tube further down and pull a washcloth along it, you will physically drag the tube outward. Remember that balloon inflated inside the bladder? When you tug the tube, that balloon slams against the sensitive neck of the bladder. It causes immense pain, and the friction of the tube sliding back and forth causes micro tears in the lining of the urethra.
And micro tears become breeding grounds for bacteria.
Exactly. So you stabilize it at the meatus to prevent any traction. Then, with your soapy washcloth in your dominant hand, you clean at least 4 inches down the tubing. And you must move in only one direction away from the meatus, down the tube.
I always try to think of it as a one-way street driving away from the body. You never, ever want to back up because backing up just pushes whatever bacteria is on the tube straight back into the urinary tract.
That is the perfect way to visualize it. It is a strict one-way street. You wet 4 inches down away from the body. Then, and this is critical, you adjust the washcloth to a completely clean section, and you do another stroke away from the body. You never reuse the same spot on the cloth.
This is one of those questions we see a lot on Cert Prep Academy, right?
Yeah.
Like, the direction of cleaning is an easy place to get tripped up on the exam.
Oh, absolutely. It's a very common trap. And after soaping, you repeat the exact same one-way process with a clean, wet washcloth to rinse the soap off and then dry it, always moving away from the body.
For male residents, the practice questions often throw in an extra detail about uncircumcised anatomy.
Right. If a male resident is uncircumcised, you must gently retract the foreskin to expose the meatus, clean the area with soap and water, and then proceed to clean outward along the catheter for those 4 inches.
And a major distractor on the exam is an option that says, avoid cleaning the insertion site to prevent dislodging the tube. That is a trap, right?
It is a dangerous trap. Avoiding cleaning it guarantees that secretions and bacteria will build up at the insertion site and cause a massive infection. Proper stabilization and gentle one-way cleaning are the absolute standards of care.
This meticulous care for skin and mucous membranes connects directly to our next broader topic. Because nutrition, elimination, and skin integrity don't exist in isolated silos. They overlap entirely with how you bathe, dress, and move a resident. You cannot maintain skin integrity if you are bathing them incorrectly, and you cannot safely get them to a commode if you don't know the physics of a safe transfer.
Exactly.
Let's look at bathing safety. The very first hazard of a bath is the water itself. What is the strict rule for water temperature?
The water must be lukewarm to warm. Specifically, the acceptable range is 105 to 110 degrees Fahrenheit, which is roughly 40 to 43 degrees Celsius.
That is a very narrow, specific window. In a clinical setting, you don't always have a thermometer handy to dip into the bath basin. How does CNA ensure the water isn't dangerously hot?
The clinical standard is that CNA must test the water physically themselves first, and you do not test it by dipping your fingertips into the basin.
Because our fingertips are used to heat.
Your fingertips are covered in a thicker layer of stratum corneum. They are calloused. They have fewer sensitive thermoreceptors on the surface compared to other parts of your body. What feels pleasantly warm to your fingers might actually be scalding. Instead, you test the water on the inner aspect of your wrist or your inner elbow.
Oh, right. Because the skin there is much thinner and more sensitive.
It much more closely mimics the fragile, paper-thin skin of an elderly resident. As people age, the epidermal layer thins dramatically and they lose subcutaneous fat. Furthermore, conditions like diabetes or peripheral neuropathy diminish the nerve endings in their skin.
Meaning they might not even feel that the water is burning them until a severe blister has already formed.
Exactly. So you rely on the thin skin of your wrist. Once you determine it is safe, the final vital step before the washcloth ever touches their body is asking the resident to verify the temperature. You place a wet cloth on their hand or arm and ask, is this comfortable for you?
You empower them to dictate their own comfort. Okay, so the water is a safe 105 degrees. Now, what is the sequence of washing? Say you were giving a complete bed bath. Does the order of body parts matter?
The order matters immensely, and it is entirely dictated by the principles of infection control. The golden rule is always start with the absolute cleanest area of the body and move systematically downward to the dirtiest area.
So the face is first.
The face is first, and specifically the eyes are first. You wash the eyes using plain water, absolutely no soap, as soap would cause chemical irritation to the conjunctiva. You wash from the inner corner of the eye, near the nose, to the outer corner.
Why inner to outer?
To prevent washing debris or bacteria into the tear duct, which is located at the inner corner, and you must use a different clean area of the washcloth for each stroke and for each eye, so you don't transfer an infection like conjunctivitis from one eye to the other. After the eyes, you use that clean water to wash the rest of the face, neck, and ears.
Which means logically the perineal area, the back, and the buttocks are the very last things you wash.
Correct. The perineal area and the buttocks have the highest concentration of bacteria on the body. If you were to wash the buttocks first and then dip that washcloth back into your basin, you would contaminate the entire basin of water with fecal bacteria. You would then be spreading that bacteria across the resident's chest, arms, and face. It is a catastrophic breakdown of hygiene, cleanest to dirtiest, always.
And a quick note on personal items during bathing. If a resident wears glasses, you don't just leave them on the bed, right?
No. You carefully remove them and place them in a safe, labeled location, like inside the bedside drawer. Leaving them on the mattress or a cluttered tray table risks them getting knocked to the floor and shattered, and you never soak them in the bath water.
All right, the bath is complete. The skin is dried via padding, not rubbing. Now it's time to dress the resident. And this specific skill is an absolute magnet for exam questions. If you look at practice questions 8, 28, and 42, they all test the exact same concept. How do you dress a resident who has a weak or paralyzed side, perhaps from a stroke or a traumatic brain injury.
They test it repeatedly because it is a very common clinical scenario, and doing it backward causes severe pain and can actually cause joint dislocations. When a resident has suffered a stroke, they often have hemiplegia paralysis on one side of the body. That arm might be flaccid and heavy, or it might be spastic and rigidly contracted inward.
Either way, it lacks normal mobility. So what is the memory aid or the rule of thumb for dressing them?
The acronyms most commonly taught are POW and TOSS. POW stands for put on weak. TOSS stands for take off strong side.
POW. Put on weak. So if a resident has left-sided paralysis and you're putting a button-down shirt on them, the weak left arm goes into the sleeve first.
Yes, you always dress the affected or weak side first. Let's look at the biomechanics of why. If you put the strong right arm in first, the shirt is now anchored to that side of the body. You then have to stretch the fabric tightly across their back, grab their paralyzed, unmoving left arm, and try to force and bend it backward to jam it into the remaining sleeve.
It's like trying to thread a rigid pipe through a bent sleeve. You are fighting the fabric and the anatomy.
And in doing so, you are putting massive torque on the shoulder joint. The rotator cuff is very easily torn in paralyzed limbs. By dressing the weak side first, you can gently guide the flaccid arm into the bunched up sleeve without any tension on the fabric. Once the weak side is safely in, the resident can use their own strong arm to reach back, grab the other sleeve, and help pull the garment into place.
It is basic physics. You minimize the strain on the compromised joint, POW, put on weak. Okay, they are clean, they're dressed safely. Now it is time to transition them out of bed for the day. Safe transfers and ambulation. Before you even attempt to put a gait belt on them, before you even ask them to sit up, what is the absolute first physical step you take with the bed?
You must lock the wheels of the bed. It is step one, always.
Locking the wheels is an instant fail on the skills test, and if you've been using Cert Prep Academy, you've probably seen it pop up in the multiple choice too. Why is it the cardinal rule of transfers?
Imagine the physics. A resident sits on the edge of the bed, they place their feet flat on the floor, and they push down with their legs and push off the mattress with their hands to stand up. That pushing motion exerts lateral force against the bed.
If the wheels aren't locked, the bed acts like a skateboard.
Exactly. The bed rolls swiftly backward away from them. Their base of support instantly vanishes, their center of gravity plummets, and they fall backward, often striking their head on the metal bed frame or floor. Locking the wheels creates a static, immovable base for the transfer.
Okay, the wheels are firmly locked. You help the resident roll to their side, drop their legs over the edge, and sit up. Do you immediately stand them up and start walking?
No, absolutely not. Once they are sitting upright on the edge of the bed, you must let them sit there and dangle their legs for at least a full minute.
Dangling. The practice exams love this concept. Let's break down the physiology of why we dangle. It's to prevent orthostatic hypotension, correct?
Correct. Orthostatic hypotension is a rapid, sudden drop in blood pressure that occurs when you change positions quickly, specifically going from a horizontal lying position to a vertical sitting or standing position.
How exactly does that happen in the body?
Think of your vascular system as a closed loop of fluid-filled pipes. When you are lying flat in bed all night, gravity is distributed equally across your entire body. Your blood flows easily. When you suddenly sit up, gravity instantly pulls a massive volume of that blood straight down into the veins of your legs and abdomen.
In a healthy young person, we don't pass out every time we get out of bed. Why?
Because of baroreceptors. These are pressure sensors in your arteries. In a young person, the moment the baroreceptors sense the blood dropping toward the legs, they send a lightning-fast signal to the brain. The brain immediately orders the blood vessels in the legs to constrict, squeezing the blood back upward to maintain blood flow to the brain. It happens in milliseconds.
But in the elderly population,
In the elderly population or in residents taking blood pressure medications, those baroreceptors are sluggish. They don't fire as quickly, the blood vessels are stiffer, and don't constrict as fast.
so the blood literally pools in their legs.
Yes, and if the blood is pooled in their legs, it is not flowing to their brain. The brain is momentarily deprived of oxygen. The resident experiences severe dizziness, spots in their vision, and profound weakness. If you force them to stand up the second they swing their legs over the bed, their brain will simply shut down to force them back to a horizontal position. They will faint and fall to the floor.
So letting them sit on the edge of the bed and dangle their legs gives their sluggish autonomic nervous system the time it needs to constrict those vessels and equalize their blood pressure before they bear their full body weight.
It is a simple 1-minute pause that prevents catastrophic head injuries and hip fractures.
Yeah, Cert Prep Academy has a whole section on transfer safety, and this is exactly why. Okay, so they have dangled. The dizziness is past. They are standing up, and we're going to go for a walk down the hall, ambulating. Where exactly should the CNA position themselves during this walk?
You should position yourself on the resident's weak side, standing slightly behind them.
This always tripped me up. Intuitively, I feel like I should stand on their strong side so I can hold their strong arm and pull them forward, or let them lean heavily on me.
You are not there to tow them, and you are not a crutch for them to lean their entire body weight on. If you stand on their strong side, you are taking away the side of their body that has the best balance and reflexes. They should be using their strong hand to hold onto a handrail or a cane.
So you stand on the weak side because that is where the vulnerability is.
Exactly. Their weak side is the side most likely to buckle, drag, or lose its balance. If you are standing slightly behind them on the weak side, often holding a gait belt securely around their waist, you are in the optimal biomechanical position. If their weak knee buckles, you are right there to support their center of mass and gently guide them down your own leg to the floor, rather than letting them crash forward.
And if they are using a walker?
The same rule applies. You walk to the side and slightly behind them. You never stand directly in front of them walking backward because you are blocking their line of sight and creating a tripping hazard. And if you are on the opposite side of the room, you are useless if they lose their balance. Proximity on the weak side is key.
We have covered so much physical ground today, from the anatomy of swallowing, to the chemistry of skin breakdown, to the physics of walking. But we have to address the philosophical core of all of this. Woven through every single one of these physical tasks is the resident's absolute right to autonomy. This is the tension between what is medically prescribed and what the resident actually wants.
It is the ethical friction of caregiving. And it trips up a lot of well-meaning caregivers, and it features heavily on the NNAAP exam. What is your response when a resident looks at you and simply says no?
Right. We see this in practice question 7. You walk into a room to give a scheduled bed bath, and the resident refuses because they say the room is too cold. Or practice question 38, where a resident is supposed to ambulate down the hall, but they refuse to use their walker today. Your entire job description is to keep them clean and keep them safe. If they refuse to let you do your job, can't you just insist?
You absolutely cannot force them. In a healthcare setting, forcing a resident to undergo a physical intervention they have explicitly refused is legally considered battery. A resident retains the fundamental human, ethical, and legal right to refuse any treatment, medication, or personal care.
So what is the actual procedural response? If they say no, do you just say, all right, my shift just got easier, document it, and walk away?
Doing so would be medical neglect. You must respect the refusal, but you also have a duty to investigate the why and offer accommodations. Beneficence, the duty to do good, requires you to explore alternatives.
So if they say they are cold.
You validate it. I understand the room feels drafty. Would it be all right if I turned the thermostat up and brought you a warm blanket and we can try the bath again in an hour when you're comfortable? You negotiate. You adjust the environment to remove the barrier.
And if they still firmly say no?
Then you accept it gracefully. But your duty does not end there. You must formally document the refusal in their chart, and you must report it verbally to the charge nurse.
Why is the verbal report to the nurse so critical?
Because the nurse needs to analyze patterns. A resident skipping a bath one morning because they are tired is not an emergency. But if you report that they have refused a bath for 4 consecutive days, the nurse now has the data to come assess the resident. Is the resident developing severe clinical depression? Do they have a hidden skin tear they are embarrassed about? Are they in physical pain?
The refusal is a symptom, and the nurse needs to know about it to treat the underlying cause. And in the case of the walker,
If they refuse the walker, perhaps it isn't just stubbornness. Perhaps the grips on the walker are aggravating their arthritis, or the height of the walker is hurting their back. By reporting the refusal, the nurse can request a physical therapy evaluation to adjust the equipment.
that brings us beautifully to the concept of adaptations. Promoting a resident's independence isn't about leaving them to struggle unassisted. It is about actively providing the tools that allow them to succeed.
Precisely. Let's return to the feeding scenario. Say you have a resident with severe rheumatoid arthritis. Their hands are stiff, and they physically cannot close their grip tight enough to hold a thin standard metal spoon.
The instinct of a compassionate caregiver is to say, "Don't struggle, let me feed you." But we've discussed how that strips away their autonomy.
It strips their dignity and accelerates their physical decline. Use it or lose it applies fiercely to muscle memory and joint mobility in the elderly. Instead of taking the task away from them, you provide an adaptation. You offer utensils with thick, built-up foam handles.
Because a thicker handle requires significantly less fine motor control and a much wider, looser grip.
Exactly. The same principle applies to grooming. A comb with a built-up handle or an extended reach allows them to brush their own hair without having to flex their painful shoulder joints as far or grip as tightly. You do the task with them, providing the adaptive scaffolding rather than doing the task for them.
You encourage them to participate in the exact margins of what they are capable of doing, and you only step in to assist with the specific mechanics they cannot safely manage.
It is the ultimate expression of respect.
And that observation extends to their emotional state as well. Practice question 1 sets up a very nuanced scenario. A resident requests your help with grooming, so they aren't refusing care, but as you are helping them, you notice they appear incredibly withdrawn, sad, and flat. What is the CNA's role here? You aren't a psychologist.
You aren't a psychologist, so you don't pry with invasive diagnostic questions. Why are you depressed today is inappropriate and confrontational. But ignoring their flat affect is also a failure of care. The best response is to proceed with the requested grooming assistance, maintaining a calm, supportive, and unhurried presence. You hold space for them.
Amen.
And then you observe their emotional cues closely, and you report those precise observations to the nurse. You are the frontline eyes and ears of the entire clinical team. The doctor sees the resident for 5 minutes a month. The nurse sees them for brief assessments and medication passes. You, the CNA, spend hours with them every single day.
So you are the one who notices the subtle baseline shifts. You notice when the normally chatty resident goes silent?
Exactly. You are the vital early warning system for signs of depression, cognitive decline, or silent physical pain.
It's a consistent theme. When you're stuck on a Cert Prep Academy practice question, ask yourself, which answer protects the resident's dignity and independence the most? If you can find the answer that balances those two scales, you have almost certainly found the correct answer.
It is an impeccable rule of thumb for passing the written exam, and it is the ethical foundation of a long, meaningful career in healthcare.
We have covered an immense amount of physiology and technique today. Let's consolidate this. I'm going to ask you for a rapid-fire 1-minute recap of the absolute most critical takeaways from this deep dive. Ready? Go.
All right. Feeding. Gravity is your friend. The resident must sit upright at a 75 to 90 degree angle to prevent aspiration. Emergencies. If they cough while eating, stop feeding and assess, never give water. If they vomit during a tube feeding, stop the pump immediately and roll them on their side. Elimination. Plastic pads trap heat and cause maceration. Prompt perineal care prevents chemical burns from ammonia. Bedpans. Always elevate the head of the bed to semi-fowlers to mimic natural posture. Catheters. Wash daily with soap and water, stabilize the tube at the meatus to prevent tearing, and clean at least 4 inches outward, strictly away from the body in a one-way street. Bathing. Water must be 105 to 110 degrees, tested on your inner wrist. Wash from cleanest to dirtiest, eyes first, back and buttocks last. Dressing. POW put on weak side first to protect the joints. Ambulation. Lock the bed wheels, let them dangle for a minute to prevent orthostatic hypotension, and guard them by standing on their weak sides, slightly behind. Finally, respect refusals, offer adaptations, and continually observe and report to the nurse.
That is a masterclass in the 14% of the ADL content outline. Now, you want to test your retention on the exact scenarios we just discussed, head over to certprepacademy.com. The platform is completely free. There is no sign-up required to get started. There's a full 70-question practice test that mirrors the real NNAAP exam perfectly. You'll find free study guides covering every single topic on the test and digital flashcards to help you lock in these vital terms. Everything you need to pass is in one place, and it costs nothing. Head over to certprepacademy.com right now. The link is right there in the description.
Use the practice questions. Understanding the physiology is step one, but practicing how the exam formats those scenarios is what secures your passing score.
We will be right back here with you for episode 4 of the series, where we will keep marching through the content outline. Keep studying hard. Trust your knowledge. You've got this.
Approach every practice question and every future resident interaction by remembering the profound vulnerability at play. You're managing the invisible rhythms of their life.
Thanks for joining us on this deep dive. See you next time.